Welcome to the MCAT Basics podcast, brought to you by the physicians at Med School Coach. Each week, Sam Smith breaks down high-yield MCAT topics so you can score as high as possible on test day.
Welcome to MCAT Basics. I'm Sam Smith, and this episode covers psychological disorders. I'm first going to talk about what a psychological disorder even is, and then I'll talk a little bit about how they're classified. And then I'll get into the different types of psychological disorders to know. This includes anxiety disorders, obsessive-compulsive disorder, trauma and stressor-related disorders, somatic symptom disorders, bipolar disorder, depression, schizophrenia, dissociative disorders, and finally, personality disorders. After that, I'll talk about the biological bases of several different nervous system disorders. That will include schizophrenia, depression, Alzheimer's, and Parkinsons. With that said, let's dive into it, and I hope you find this podcast helpful. So I want to start by talking about what exactly a psychological disorder is. And this episode, by the way, was pretty interesting for me to do research on because it's not always been very clear to me what is considered a psychological disorder and what's not considered one. You know, to me, it's always been this blurry line where on one side you have a psychological disorder and on the other side you have the everyday human experience where you experience anxiety, doubt, sadness, just all of these things that are human. So I've always kind of wondered when those feelings that, you know, is kind of part of the human condition, when does that turn into a psychological disorder? And I'm sure you'll learn a bunch more about that during your psychiatry rotation. I hope I will too. But what I'm going to try to do in the first part of this podcast is kind of define what exactly a psychological disorder is. So according to a journal article that was published in 2007 by 3 different psychologists, quote, a psychological disorder is an ongoing dysfunctional pattern of thought, emotion, and behavior that causes significant distress and that is considered deviant in a person's culture or society, end quote. Now, in that definition, there are really 2 kind of key takeaways, or at least there's 2 things that I take away. Those 2 takeaways are number 1, the word deviant, and number 2, the word significant stress. So then, based on that definition, in order for behaviors, thoughts, feelings to be considered a psychological disorder, they need to cause significant stress and or result in behavior that is deviant from society. In other words, it has to result in behavior that is breaking some norm within whatever society that individual is living within. That, of course, then raises the question, what exactly is significant stress? Seems like a pretty subjective term, and it definitely is a subjective term. I mean, I feel like I almost need like a lawyer or something to get to the bottom of that. No, but I guess it probably depends upon the individual that's experiencing the emotional/mental disorder and what they considered to be significant, right? For one person, you know, just sadness and depression and, you know, anxiety that they experience in their life, that may not cause them significant stress and therefore maybe wouldn't be considered a psychological disorder. On the other hand, another person that, say, experiences the exact same things as the person I was just describing, to them that could cause them significant stress, and therefore their feelings of anxiety, depression, sadness, etc. would in fact meet the criteria to then be a psychological disorder. Anyways, I think the big takeaway here is that in order for thoughts, feelings, emotions, behaviors to be considered psychological disorders, they need to cause significant stress and result in deviant behavior. Now, with that said, there are several approaches to thinking about or further defining psychological mental conditions. These fall into one of 2 categories. The first approach is called the biopsychosocial approach, and the second is called the biomedical approach. The biopsychosocial approach tries to understand disease, specifically psychological disorders, using biology, psychology, and the social situation of the patient that is suffering from that disorder. Hence its name, biology, psychology, social situation. Now, what exactly do each of those 3 terms kind of mean in the context of a psychological disorder or disorders in general? Well, the bio part focuses on pathophysiology. So that tries to understand the disease using kind of conventional methods, understanding, maybe changes in brain chemistry, changes in neurotransmitter levels, etc. when you're talking about a psychological disorder. Psycho or psychology refers to thoughts, emotions, and behaviors that are related to a certain disorder. This could be things like psychological distress, fear and avoidance beliefs, and current coping methods. And then the social or social situation refers to socioeconomical, socio-environmental, and cultural factors that play a role in disease. This is things like work issues, family circumstances, benefits, the economics of the person, how much money do they make, can they afford their medication, can they afford to get treatment, etc. A paper I read on this perspective called Biocycle Social Model in Contemporary Psychiatry, Current Validity and Future Prospects says, quote, "The biopsychosocial perspective explains that a person does not suffer as isolated organs, but rather as a whole. This provides a holistic approach to psychiatric illness. The emotional tone of a person, his or her personality, their surrounding environment, and other social parameters do influence the manifestation of a psychiatric illness." End quote. Basically, this perspective takes a holistic approach to understanding the mental state of a patient or understanding the psychological disorder that that patient has. Proponents of this approach would say that it treats both the symptoms and the underlying cause of a psychiatric disease. So that's the biopsychosocial approach to looking at psychological disorders. As I mentioned a little bit ago, the other approach is called the biomedical approach. Now, the biomedical approach is kind of like the traditional approach to looking at a disease. In terms of psychological disorders, it kind of looks at them as like brain diseases, and it also emphasizes the use of drugs in treating them. For example, let's say that you're treating a patient that has depression. If you're using the biomedical approach, you might ask questions like, what are the abnormalities in the brain of someone who's suffering from depression? And what drugs can I prescribe in order to reverse these abnormalities? In other words, this approach looks at psychiatric disorders only through the lens of pathophysiology. It's basically just the bio part of the biopsychosocial perspective. Now, proponents of the biopsychosocial perspective would say that the biomedical approach treats just the symptoms of disease, not the underlying cause. So just to kind of reiterate and summarize what I was saying there, the biomedical approach looks at psychological disorders as brain abnormalities, whereas the biopsychosocial approach looks at them in the context of biology, like the biomedical approach does, but it goes a little bit further because it looks at it in the context of psychology, as well as the social conditions of the person that is experiencing that disease or that disorder. And according to that same paper I mentioned earlier, ever since its conception in 1977, the biopsychosocial perspective has continuously gained traction in the field of psychiatry. It's now kind of widely used and widely accepted by the field. I'm sure you're going to hear a lot more about this perspective and probably learn how to kind of use it in order to diagnose psychological disorders and probably treat them in your psychiatry rotation in med school. So I'll leave it there and I'll move on and I will talk about how psychological disorders are classified. But first, a message from our sponsor, Med School Coach.
At Med School Coach, we know that studying for the MCAT exam can be challenging, especially for busy students on the go. That's why our team created MCAT Prep, the only all-encompassing study app built specifically for the MCAT. MCAT Prep by Med School Coach provides student access to extremely high-quality content and a personalized curriculum for free. The app has more than 250 videos, 1,000 flashcards, and 1,000 unique MCAT questions. Plus, MCAT Prep by Med School Coach allows students to create a personalized study schedule and track progress over time. You need every competitive advantage you can get to get into medical school, and now you can put the experts from Med School Coach into your pocket. It's the closest pre-med students can come to a personal tutor without spending a penny. Download MCAT Prep by Med School Coach for free at medschoolcoach.com/MCAT. Or download it directly from the Apple Store or Google Play Store. You can achieve your medical school dreams, and MCAT Prep by Med School Coach can help.
All right, the next thing I want to talk about here is how psychological disorders are classified. So I'm sure there's a bunch of different ways that one could classify psychological disorders. I could come up with a list and classify them in whatever way I wanted to, but in the context of medicine, psychological disorders are classified according to the Diagnostic and Statistical Manual of Mental Disorders, the DSM. And every so often, this thing gets updated. We've had, I believe, the DSM 1, 2, 3, 4, and 5. We currently are on the DSM 5. So the most up-to-date classification of psychological disorders lives in this DSM 5. And when you open up the DSM 5, you'll notice a few things right away. First of all, it's thick as hell. It's like 900 pages long. So this thing is basically the Bible of psychological disorders. The other thing that you would notice is that it has a bunch of different categories that each and every psychological disorder fall into. And what I'm going to do here is I'm going to give you kind of the main categories that are in the DSM-5. And don't worry about memorizing them for the MCAT. That would be stupid. Instead, what I'm trying to do here is I'm just trying to give you an idea of what the DSM-5 says and just how comprehensive it is, because it's super comprehensive. So overall, it categorizes psychological disorders into the following main categories: neurodevelopmental disorders like autism, schizophrenia spectrum disorders like schizophrenia, bipolar and related disorders, bipolar 1 and 2 fall into this category, depressive disorders, obviously major depression falls into that category, anxiety disorders, that's things like panic disorder, generalized anxiety disorder, etc., obsessive-compulsive related disorders like OCD, trauma and stressor-related disorders like PTSD, post-traumatic stress disorder, dissociative disorders like dissociative amnesia, somatic symptom disorders, feeding and eating disorders like anorexia nervosa, elimination disorders like enuresis, aka bedwetting, sleep-wake disorders like insomnia, breathing-related sleep disorders like sleep apnea, parainsomnias like nightmare disorder, sexual dysfunction like ED, gender dysphoria, disruptive impulse control and conduct disorders like pyromania, who knew that is actually a psychological disorder, substance-related and addictive disorders, alcohol use disorder falls under that category, and guess what else does? This is a little bit scary, but there is actually a subcategory called caffeine-related disorders. So drinking too much coffee, I guess, could be considered a psychological disorder. Neurocognitive disorders like delirium, personality disorders, and finally paraphilic disorders like fetishistic disorder. So based on that super comprehensive list of psychological disorders, it should be no surprise that many people in the US have been diagnosed with a psychological disorder. According to Johns Hopkins, approximately 26% of the US population has a diagnosable psychological disorder. That's literally 1 in every 4 people. Literally. And not to mention, a lot of people suffer from multiple of these psychological disorders. And that begs the question, why is there so many people in the US that have psychological disorders? Well, that, my friends, is the million-dollar question. And there's 1.5 million perspectives and theories on why that is. Some people suggest that wealth inequality has gotten a lot higher, and that correlates with the higher rates of mental disease and psychological disorders that we see in society. The rise of social media and its impact on people's mental health is another theory as to why this rate is so high. There's another perspective that says we as a society and as a medical profession overdiagnose and medicalize things that aren't necessarily diseases. So I brought up earlier the caffeine-related disorders that are in the DSM-5. That, to me, is maybe a little bit of medicalization, turning something that isn't necessarily a medical condition and making it into one. Just my opinion. But anyways, there is a perspective out there that says that the medical community has overdiagnosed and medicalized things that were not medicalized before, and thus we see a higher rate of these psychological disorders within society. Now, which of these perspectives is actually right? Who knows? In all honesty, it's probably a combination of all of these things, plus 1,000 more. Anyways, the next thing I want to do here is I want to introduce the different types of psychological disorders that the AAMC wants you to be familiar with for the MCAT. This includes anxiety disorders, obsessive-compulsive disorder, trauma and stressor-related disorders, somatic symptom disorders, bipolar and related disorders, depressive disorders, schizophrenia, dissociative disorders, and finally, personality disorders. So I'll go through each of these one by one, talk a little bit about what each of them mean, give some examples, and just try to get you a little bit more familiar with each of them. Now, before I dive into each of these, just know that the descriptions for each of them come straight from the DSM-5. All right, so let's start with anxiety disorders. So anxiety disorders are disorders that share features of excessive fear and anxiety. Now, fear itself is defined as the emotional response to a real or perceived threat, and anxiety, on the other hand, is defined as the anticipation of a future threat. Now, I think everyone feels anxious, at least to some extent, every day. So how exactly do anxiety disorders differ from normal day-to-day anxiety? Well, anxiety disorders differ from just a normal anxious or fearful feeling by being excessive and persisting beyond what's normal. Another thing I want to mention here is that panic attacks are a common symptom of anxiety disorders. And there's quite a few different disorders that fall under this kind of category. This includes separation anxiety disorder, selective mutism, social anxiety disorder, generalized anxiety disorder, and panic disorder. So just to kind of summarize that for you, anxiety disorders are disorders in which someone has excessive amounts of fear and anxiety, more than what are normal. Next is obsessive-compulsive disorder. This is one you've probably heard of before, and it's characterized by the presence of obsessions and/or compulsions. Obsessions are recurrent and persisting thoughts, urges, or images that are unwanted. On the other hand, compulsions are repetitive behaviors or mental acts that an individual feels driven to perform in response to an obsession or according to rules that they need to follow kind of rigidly. So, for example, an obsession might be something like the constant fear of blurting out obscenities or insults when you're sitting in class, and then you can't get that thought out of your mind, and thus you just can't pay attention in class. That's an obsession, right? That's something that is not actually going to happen, but you just can't get your mind off of. An example of a compulsion, on the other hand, is like ordering or arranging things in a particular way. This would be like a student getting anxious if the books or papers on their desk are not symmetrically aligned or like a certain distance away from each other. That's a compulsion. Now, there are multiple psychological disorders that fall under this category. The first of which, obviously, is obsessive-compulsive disorder. Another one is body dysmorphic disorder. There's hoarding disorder. One called hair-pulling disorder, which I don't even want to try to pronounce. Excoriation disorder, which is like skin-picking disorder. And then finally, substance/medication-induced obsessive-compulsive disorder. So that's obsessive-compulsive disorder, and again, it's characterized by the presence of obsessions, which are these thoughts you can't get out of your mind, and/or compulsions, which are repetitive actions. Next, we have trauma and stressor-related disorders. These are disorders in which someone has been exposed to or experienced some traumatic event. So this includes things like post-traumatic stress disorder, PTSD, reactive attachment disorder, disinhibited social engagement disorder, acute stress disorder, and adjustment disorder. Patients that suffer from these kinds of disorders can have symptoms like anxiety, dysphoria, which is basically dissatisfaction with life. They can have these angry, aggressive kind of outbursts, or they can have dissociation. So they can have a really wide variety of symptoms, but what really sets this type of disorder, the trauma and stressor-related disorders, apart from other things is that they all stem from some sort of traumatic event, like, for instance, watching, someone die during war or, losing a loved one in a way that's very traumatic. So again, trauma and stressor-related disorders are psychological disorders that stem from some traumatic or stressful event. The next group of psychological disorders to know are called somatic symptom disorders. This is probably something that you haven't heard of before, or maybe you have. But anyways, somatic symptom disorders all share one common feature, and that's the prominence of somatic symptoms associated with significant mental distress and impairment. Now, that probably makes you think, what the H is a somatic symptom? I've never heard of that before. Well, a somatic symptom is just some type of physical symptom, and that could be anything from, breaking your leg to dislocating your hip to, I don't know, pulling out a fingernail, just some type of physical pain or physical symptom. So then this psychological disorder, somatic symptom disorder, is basically when a person gets anxious about some physical symptom that they had, physical symptom that they have. And then this anxiety or this stress goes on to affect their day-to-day life in a big way. Now, there are basically 3 different diagnostic characteristics for diagnosing someone with a somatic symptom disorder. First of all, they have to have some sort of somatic symptoms. As I just mentioned, this is some sort of physical symptom like leg pain. Number 2, they have to have excessive thoughts, feelings, or behaviors related to their somatic symptom. And these are usually negative thoughts and negative feelings. And then finally, number 3, these thoughts and feelings and behaviors are persistent. The DSM-5 says that these symptoms have to last for more than 6 months. Now, I have a kind of personal example of this. It's a little bit close to home for me, a little bit heavy for me. Cut the shit, it's not that heavy. But one of my loved ones at some point pretty recently had a hip surgery. And the hip surgery was essentially to fix hip dysplasia, where the hip socket, I guess, doesn't fully cover the ball portion of the upper thigh bone. It's something you've probably heard about like in dogs. I don't know, for whatever reason, dogs tend to get hip dysplasia quite a bit. Anyways, she had to undergo this procedure called a PAO, which I'm going to try to pronounce it, periace tubular osteotomy. It's a pretty major procedure. Essentially, they break the hip at 3 points. They rotate it so that the hip socket is then fully covering the ball portion, and then they glue it back together and you recover. And the recovery is pretty long. It's like a year long. And I know during her recovery, she had a lot of negative thoughts. She thought, will I ever be able to walk again? When am I going to get back to normal? Will I ever be able to run again? Will I be able to hike? And if so, if I can't, what's the point of being on this earth? Those are my favorite things, playing sports, hiking, etc. Why should I be around if I can't do those things? So those are negative thoughts that are associated with somatic symptoms, which the somatic symptom here is just, hip pain and undergoing a hip surgery. Now, those thoughts weren't persistent. She got over them in less than 6 months. So she was never diagnosed with a somatic symptom disorder. But if she was to continue to have those persistent thoughts, that would be then considered a somatic symptom disorder. Next are bipolar and related disorders. These are disorders that bring severe high and low mood swings, which are called manic episodes, high mood swings, and depressive episodes, low mood swings. They also bring changes in sleep, energy, thinking, and behavior. So in short, when you think of bipolar disorder or associated diseases, think of mood swings. Now, with that said, it's important that you understand the difference between 2 types of bipolar disorder, bipolar 1 and bipolar 2. As a start, both of these involve mood swings. Now, there's kind of one key difference between bipolar 1 and bipolar 2. So bipolar 1 involves manic to major depressive mood swings. So manic, of course, is a high, and you go down to major depressive mood swings, which are low. On the other hand, in bipolar 2, you have less severe mania. You have hypomania episodes, is what they're called. Basically, these individuals that suffer from bipolar 2 don't have as severe of these upswings in mood. In other words, they don't get up to mania. They get up, right below mania to hypomania. Still, though, it's important to note that these individuals do have the major depressive mood swings. So again, bipolar 2 involves hypomania, bipolar 1, mania. And typically, or I guess historically speaking, bipolar 2 was kind of thought to be like the less severe form of bipolar disorder. However, the DSM-5 says, no, not quite true. It says, quote, Bipolar 2 is no longer thought to be a milder condition than bipolar 1 disorder, largely because of the amount of time individuals with this condition spend in depression and because the instability of mood experienced by individuals with bipolar 2 disorder is typically accompanied by serious impairment in work and social functioning. End quote. So that's just something to kind of keep in mind when it comes to bipolar 1 versus bipolar 2, right? Bipolar 2 has these not so high ups because you have hypomania versus mania in bipolar 1, but that doesn't mean that bipolar 2 is like less severe of a condition than bipolar 1. Next are depressive disorders. The common feature of all depressive disorders is the presence of sad or empty feelings, irritable mood, accompanied by somatic and cognitive changes that significantly affect the individual's capacity to function. Simply put, a depressive disorder is where someone feels depressed to the point where it affects their day-to-day life and they can't function the way that they should or the way that they want to. This group of disorders, again, depressive disorders, includes things like disruptive mood dysregulation disorder, major depressive disorder, which is kind of the classic form of depression. It's characterized by discrete episodes of depression that last at least 2 weeks in duration. Persistent depressive disorder, and premenstrual dysphoric disorder. Now, with that said, one thing that I thought was kind of interesting that the DSM-5 says about depression is that it says careful consideration is given to the delineation of normal sadness and grief from a major depressive episode. Bereavement may induce great suffering, but it does not typically induce an episode of major depressive disorder. In other words, it kind of instructs psychiatrists to be careful not to mistake like the normal grieving process and normal sadness that, comes with life with depression. In further other words, it's instructing psychiatrists not to overdiagnose people with depressive disorders. Next is schizophrenia. So schizophrenia is a psychotic disorder, and there are a few key features that define psychotic disorders, at least given by the DSM-5. The first is delusions. The second is hallucinations. The third is disorganized thinking or disorganized speech. The fourth is abnormal disorganized behavior. And the fifth is negative symptoms. So someone with schizophrenia will have some of these symptoms. Now, what I want to do next is I want to break each of these different groups of symptoms down a little bit further. Let's start with the delusions. So delusions are fixed beliefs that a person does not change even in light of conflicting evidence. There's a great example of this that I saw in like a documentary the other day, and the example is this. So in 1981, a man named John Hinckley attempted to assassinate Ronald Reagan, who at the time was president. And when he was asked about his reasoning, he said he did it all to impress the person he was absolutely in love with. And who was that person? Well, it was actress Jodie Foster. He absolutely believed that he had some sort of relationship with her, even though he had never even met her, let alone talked to her. And, when he was arrested, the police tried to kind of convince him that there was no way that he had an actual relationship with her. They told him, you've never seen her, you've never met her, etc. But he still wouldn't budge on this idea. And that's a delusion, right? It's a belief that's illogical, that doesn't change even when there is contradictory evidence that's presented against that belief. Now, hallucinations are perception-like experiences that occur without an external stimulus. In other words, there's some sort of visual, auditory, or other perceptual experience that seems completely real, but isn't really there. This could be things like voices talking in someone's head, or imagining someone is in front of you and talking to that person even though they're not there. The next symptom I mentioned was disorganized thinking, and the reason that I also said disorganized speech is because this is typically assessed by listening to someone talk. The DSM-5 says that the individual may switch from one topic to another. Answers to questions may be obliquely related or completely unrelated. So this characteristic or this symptom is pretty much exactly what it sounds like. A person's thoughts are disorganized and scattered, and so they're not able to communicate properly. Next is abnormal or disorganized behavior. Apparently, this manifests itself in several different ways, from a person acting childlike or acting silly to unpredictable agitation. It also includes catatonic behavior, which is basically a marked decrease in the reactivity that a person has to their environment. Basically, think of someone sitting completely still and silently in place and just kind of staring off into the distance and not answering any questions, not even responding to stimuli. You could snap your fingers in front of their face and they're just not going to do anything. They're just continue staring off into the distance. That's catatonic behavior, and that is a symptom of schizophrenia. Now, finally, the last characteristic or symptom I want to talk about here is negative symptoms. These are things that decrease or are absent because of schizophrenia. Now, to really kind of understand what I mean by negative symptoms, I need to first mention what a positive symptom is. So negative symptoms are, of course, in opposition to positive symptoms, which positive symptoms are things that are added on to normal behavior, and that includes all of the symptoms I talked about previously, right? Hallucinations are in addition to normal behavior. Delusions are in addition to normal behavior. So are the other ones. Now back to negative symptoms. Again, these are things that are taken away. There are really two prominent negative symptoms that appear in schizophrenia. The first is diminished emotional expression, and the second is avolition. Diminished emotional expression is kind of what it sounds like. It includes things like reductions in the expression of emotions in the face, less eye contact, no movements of the hand, head, and face that would normally give an emotional emphasis to speech, as well as flat affect. Avolition, on the other hand, is a decrease in motivated, self-initiated, purposeful activities, like, for example, work. So an individual that suffers from schizophrenia may just kind of sit for long periods of time and essentially do nothing, not participate in work, social activities, etc. So those are kind of the 5 characteristics of schizophrenia. Now, does a person have to have all 5 of these to be diagnosed with schizophrenia? The answer to that is no. A person has to have essentially 2 or more of those characteristics that are each present for a significant portion of time, that being more than 1 month. And finally, we have made it to the very last psychological disorder I want to talk about, or I guess group of disorders. They are dissociative disorders. Actually, never mind, I lied. The last one is personality disorders, but as you'll see when I get to them, I cover that in another podcast, so I'm not really going through them. Anyways, dissociative disorders are characterized by a disruption and or discontinuity in the normal integration of consciousness, memory, identity, emotion, perception, body representation, and behavior. Basically, this is a set of disorders in which a person recurrently disassociates in some form from reality. Now, with that said, there are 2 basic categories for the symptoms of a dissociative disorder. The first being positive symptoms and the second being negative symptoms. Positive symptoms are essentially where an individual loses their sense of reality and starts seeing things that aren't necessarily there, or even taking on different identities. And there's actually a disorder called dissociative identity disorder, aka multiple personality disorder, where someone has like discrete different personalities and they kind of switch between them. So that's a positive symptom. On the other hand, negative symptoms include the inability to access information or control mental functions that normally are easy to control or access. One of the main disorders that has these negative symptoms is called dissociative amnesia. This is where you have the inability to remember things that happened to you. Typically, it occurs after some traumatic event, but you just can't, you literally can't recall what actually happened. And that brings up another good point, which is that this group of disorders, again, dissociative disorders, usually occur after someone experiences severe trauma. So those are dissociative disorders, and again, they're characterized by a disruption and or discontinuity in the normal integration of consciousness, behavior, memory, perception, aka a person disassociates or parts with reality in some way. And that brings me to the last type of psychological disorder that I want to talk about, personality disorders. Now, as I kind of alluded to earlier, I talked about these personality disorders in pretty good detail in the personality podcast. So if you want to hear a lot about these and hear about them in great detail, go listen to that. What I'm going to do here is just kind of introduce them. So in general, a personality disorder is an enduring pattern of behavior that deviates markedly from the expectations of an individual's culture and is also pervasive and inflexible. And typically, these personality disorders come on in adolescence or early childhood. Also, they are stable over time. And finally, they lead to distress or the impairment of an individual that suffers from them. And overall, there are 10 different personality disorders, and they're grouped into 3 different clusters, either cluster A, cluster B, or cluster C. And again, if you want to hear kind of a deep dive into these personality disorders, go listen to the Personality podcast. I think the big takeaway here, though, is that these personality disorders are a long-term pattern of behavior that is pervasive and inflexible. It comes on early in life, and it leads to distress or impairment for the individual that suffers from it. If you're going to take anything away about personality disorders, take that. All right, so those are the psychological disorders to know. Again, I would just kind of have a basic understanding of what each of them are and maybe some of the symptoms, some of the characteristics of each. Now, the next thing I want to talk about is the biological basis of some nervous system disorders. I'll talk about the biological basis of schizophrenia, depression, Alzheimer's, Parkinson's disease, and then lastly, I'll talk about how stem cell-based therapies can be used to actually regenerate neurons in the central nervous system in the brain, which can be used to treat some of these disorders. I'll start with schizophrenia after the break.
At Med School Coach, we know that getting into medical school is hard. In fact, 60% of pre-meds who apply to medical school don't even get accepted. And if you want to get accepted into a top medical school, it's even harder. It's a complicated process, and even students with great grades and MCAT scores get left out. That's why more students than ever are turning to Med School Coach for admissions advising. Our advisors are all physicians and former admissions committee members, so they know exactly what medical schools are looking for. One-on-one admissions advising from Med School Coach makes all the difference. Our expert team will help you develop a game plan, prepare your application, edit your essays, and coach you for interviews. Every pre-med has a story, and we'll help you tell it so you can stand out from the crowd. Visit us online at medschoolcoach.com and use offer code PODCAST10 to save 10% up to $400 on a Med School Coach admissions advising package. You can achieve your medical school dreams, and Med School Coach can help.
Okay, so we already talked a little bit about schizophrenia in terms of its symptoms. People tend to experience hallucinations as well as delusions. Then they have some negative symptoms where they kind of are withdrawn or maybe, don't show emotions like normal. And then they have a lot of disorganized thoughts or disorganized behaviors. Now, in terms of a biological basis for these symptoms, there are 3 things I really came across in my research. The first and most important is that there seems to be an increase in the release of dopamine within the brain. Dopamine, of course, is a neurotransmitter. The second is that there's a thinning of the cerebral cortex, which is the kind of outer layer of the brain. And then finally, there is a total reduction in tissue size of the brain in patients that suffer from schizophrenia. Another thing I want to mention here, and something that's really important to keep in mind, is that there is some heritable component for schizophrenia. So let me give you a few statistics, and it kind of shows this pretty easily. So the incidence of schizophrenia in the general population is about 1%. Now, if you have a second-degree relative that has schizophrenia, you have a 2.5% chance of getting it. If you have a sibling that's diagnosed with schizophrenia, you have an 8.7% chance of having it. If you have one parent who has it, you have about a 12% chance of having it. If you have 2 parents that have it, you have about a 35 to 40% chance of having it. And then finally, if you have an identical twin who is diagnosed with it, your odds are about 40 to 50% of having schizophrenia. And remember, identical twins share 100% of their genes. Further, twin studies have been done to really show that there is a genetic component to schizophrenia. Now, do we know what genes, directly play a role in causing schizophrenia? We don't. I think that's an ongoing active area of research, but the takeaway is that there is good evidence that genes play a causal role in schizophrenia. In other words, it's a heritable disease. The next neurological disorder I want to talk about here is Alzheimer's. So the symptoms of Alzheimer's are a progression of neurological symptoms that start at memory loss and confusion and slowly work their way into affecting things like motor control and eventually leading to death. Now, in terms of the biological basis of Alzheimer's, there's two biomarkers that you need to be familiar with. The first is beta amyloid plaques, and the second is neurofibrillary tangles. Beta amyloid plaques form from aggregation of this protein called beta amyloid. What happens is that for certain reasons, beta amyloid protein that is inside neurons starts to aggregate and form these big insoluble clumps or big plaques. And these plaques build up and build up and build up inside neurons, and it eventually causes the neurons to die. And ultimately, what this causes is certain parts of the brain to just die, right? You get so much neuronal cell death that actually large sections of the brain begin to die. For example, early on, as I said, kind of the first symptoms of the disease is losing memory and getting confused. Well, that's because one of the first parts of the brain to be affected by Alzheimer's and one of the first to die is the part of the brain that's involved in memory and language. And thus, you start to lose, the ability to communicate and the ability to remember. So again, beta amyloid plaques build up inside neurons, causes them to die. Now, the next thing I mentioned was neurofibrillary tangles, and these form from the aggregation of a different protein called tau. And what happens is that these aggregates of the tau protein cause tangles of the microtubule networks that make up the axons of neurons. And what ends up happening then is this blocks the communication between neurons. Neurons can no longer communicate with one another, which is obviously bad. Now, with all this said, the cause of Alzheimer's is mostly unknown, and it's the topic of a lot of ongoing research. Now, one last thing I'll mention here is that there is some interesting interplay between beta amyloid plaques and neurofibrillary tangles. So according to the NIH, the current thinking is that Alzheimer's-related brain changes may result from a complex interplay among abnormal tau and beta amyloid proteins and several other factors. It appears that abnormal tau accumulates in specific brain regions involved in memory, beta amyloid clumps and plaques between neurons. As the level of beta amyloid reaches a tipping point, there's a rapid spread of tau throughout the brain. So in other words, it seems like beta amyloid plaques actually cause these neurofibrillary tangles to form through affecting tau protein in some manner. Anyways, that's probably outside the scope of the MCAT, but still interesting. The next nervous system disorder I want to mention is Parkinson's. So you may have seen the symptoms of Parkinson's before. It's when someone has those kind of uncontrollable muscle tremors where, they can't hold a spoon and eat cereal, for example, because their hand is just so shaky and tremory. In terms of the biological basis for Parkinson's, there are kind of two major changes that come about because of Parkinson's. The first is that there is a change or a loss of neurons that make up the substantia nigra. The substantia nigra is part of the midbrain that helps us control our muscles, helps control movements and balance. The second thing to note in terms of Parkinson's and brain changes is the formation of what are called Lewy bodies. These are abnormal aggregates of protein that develop inside of nerve cells. So it's kind of similar to what happens with the beta amyloid proteins in Alzheimer's. Right, this abnormal aggregation of protein ends up kind of building up and forming these plaques inside cells, leading to cell death. So just to quickly summarize that for you, in Parkinson's, there is two biological changes in the brain that you need to be aware of. Number one, there is a change in loss of neurons that make up the substantia nigra. And number two, there is Lewy bodies that form, which are these abnormal aggregates of protein inside neurons. Finally, I want to talk about the biological basis of depression. Now, I already mentioned the symptoms of depression earlier, but it's this kind of persistent feeling of sadness or loss of interest that goes on to really cause a lot of emotional harm to somebody. Now, in terms of the biological basis of depression, there are three different things here. Number one, there is a decrease in the size of the frontal lobe, and there's a decrease in several neurotransmitters. This includes epinephrine, dopamine, and serotonin. Number two, there is an increase in several things. The first being an increase in the size of the limbic structures. There is an increase in the amount of stress hormones that are released by the body. And there's an increase in glucose metabolism within the amygdala. That just indicates that there is an increased amount of activity in the amygdala, in someone who has depression. Finally, number 3, there is abnormal neuroplasticity. In other words, there is a change in the way that neurons are hooked up to each other. Now, 2 of those nervous system disorders that I just talked about are the result of neurodegeneration, meaning that it's a disease that causes neurons in the brain to die. Those 2, of course, are Parkinson's and Alzheimer's. Now, one that I didn't talk about, but one that does the same thing, is a stroke. With that said, I can't just leave you with all this sad stuff about these neurodegenerative diseases. So I'm going to end by talking about something that can actually cure these diseases, or the hope is that they can eventually cure these diseases. And past being something that's a little more happy to talk about, as well as maybe a bit more interesting, it's something that the MCAT wants you to know about. So the therapy I'm talking about is stem cell-based therapy, and it's used to regenerate neurons within the central nervous system. And there's really 2 different ways in which this stem cell therapy can be used in order to do that. The first way is through stem cell implants, and the second way is through coaxing the endogenous stem cells in the brain to proliferate or to grow. Now, before I get into kind of what both of those mean, I first want to quickly review what a stem cell even is. So stem cells are undifferentiated or partially differentiated cells that can differentiate into various types of cells. In other words, they're cells with a blank slate. They can grow up to be cardiac cells, fat cells, any other cells. In particular, in the case that we're talking about, they can grow up to be neurons. And that brings me to the basic principle by which stem cell therapy works. It's literally regenerating nervous tissue by stimulating stem cells to grow into neurons in the brain where there has been some damage or there's been some degeneration. Okay, so that's a stem cell. Now let's get back to the 2 different ways that this stem cell therapy works in order to regenerate neurons in the central nervous system. I'll start by talking about stem cell implants. This one's pretty straightforward. In this case, stem cells are injected into the brain where degeneration is occurring or has occurred. For example, think about Parkinson's disease. As I talked about earlier, this is caused by degeneration of neurons in the substantia nigra, a little part of the brain that controls some of our motor functions. And so in that case, stem cells are injected there. And the theory then is that they will grow and produce new neurons in the substantia nigra, and then it would cure Parkinson's. Now, besides wondering if that actually works, which the answer is not yet, this should bring up another question, which is where do these stem cells even come from? Well, currently, we really haven't figured out the best source of stem cells to use in order to go on to cure Parkinson's. With that said, there are several clinical trials that are going on right now that are kind of testing this and trying to answer that question, and they're using stem cells from a variety of sources. For example, some of the clinical trials are using fetal nigral cells, some are using embryonic stem cells, others are using MSCs or mesenchymal stem cells, others are using neural stem cells from other patients, and then some are using induced pluripotent stem cells. So there's a variety of different types of stem cells that have been injected in and implanted in to try to cure Parkinson's. Again, none of them have actually worked yet, but in theory, it should work, and I'm sure eventually it will. And again, kind of the overall hypothesis of stem cell implantation is that you'll implant these stem cells and they'll grow up to be mature neurons, and thus they will kind of repair the part of the brain that has been degenerated in any of these diseases, from Parkinson's to strokes to Alzheimer's. Now, the second way that stem cells are being used to cure these diseases is through coaxing endogenous stem cells in the brain to grow. To understand what I mean by this, you first need to understand that all adults have some small amount of stem cells that naturally live in the brain. And apparently these are the remnants of stem cells that existed in the fetal brain during development. So you got these stem cells that live in the brain that are kind of leftovers from when you developed in the womb. Now, what this method kind of aims to do is to target those stem cells and tell them to divide and to differentiate into neurons. And in the end, that would do the same thing as the other method that would repair whatever part of the brain has been damaged by a neurodegenerative disease. One paper I read called this awakening of the hibernating stem cells in the brain. I kind of like that. Now, how exactly does this process work? Like, how do you get stem cells that are hanging out in the brain
to then start dividing and differentiating into neurons? Well, my understanding, and this took me a while to understand this, I think I read quite a few papers to really be able to grasp this, but what I understand is that they're coaxed to differentiate into neurons through a process where researchers provide words of encouragement and/or thoughts and prayers. Or maybe they just post the thoughts and prayers thing to social media and then they provide them directly with words of encouragement. Come on, little buddy, you got this. No, what really happens is that when these stem cells are exposed to different growth factors, aka trophic factors, then they start differentiating into neurons. Now, what factors, growth factors, encourage these stem cells to grow into neurons? We don't really know. So that's kind of what researchers are trying to figure out, is what chemicals or what drugs can I give you or maybe inject into the brain that will then cause these endogenous stem cells to grow. So as I said earlier, these strategies have not yet yielded a cure to Parkinson's or Alzheimer's or strokes, but hopefully they will one day. And that ends this podcast, hopefully on a little bit more of a positive note than some of these other, psychological disorders. Obviously, there's not much that's hopeful about psychological disorders, or that's really light. It's kind of heavy stuff. So thanks for listening to this podcast. As always, if you like what we do, please leave us a review on iTunes. Helps us in the rankings. Also, within the next few weeks, I will be passing over the podcast to another host as I prepare to start med school. So thanks everyone who's been listening to this podcast. Going to be sad to leave it, but on to somewhat bigger things. As always, too, if you have questions, feel free to email me. Happy to answer them, happy to take them. Anything MCAT related, anything med school related. My email is sam@mcatbasics.com.
Each episode of MCAT Basics is brought to you by Med School Coach. To access Med School Coach services, including MCAT tutoring and medical school admissions advising, visit our website at medschoolcoach.com. Good luck as you prepare for the MCAT, and we hope you tune in again next time.